What I'm going to talk is about culture of patient safety. Well, this seems very intrinsic to our profession, and but a lot of things change, a lot of things we learn, and particularly from other industries, and this has been triggered by the American Board of Medical Specialties almost a decade ago, and it was recommended to all the board of specialties, including the American Board of Urology, to develop a culture of safety among surgeons. And how to do that? Well, create a core curriculum, which I was involved with Team Average about 8 years ago. We started to go to courses. There are several of them, but few that you can say that it's really worthwhile. And we put a core curriculum and we published under the AUA University Core Curriculum under Ethics tab. But I'm pretty sure not a lot of people saw that. Well, there's a 2.0, a new version, and now there is the Quality Improvement and Patient Safety Committee. We're writing a white paper about certain things that are important for you to prepare when you're recertifying, and there are going to be some questions asked and trying to understand exactly what we're trying to identify as important topics. Like I said, it's very natural in our profession, the culture of patient safety. How we apply and how we communicate is maybe something that we could refine and be better. Since the medical school, since the old times, Hippocrates' oath, we do not want to harm anybody. We want to cure diseases. We want to be improving their life. We want to save lives. But if you see what triggered all this, in 1982, the TV, ABC channel, had this program about the deep sleep. The people had complications with anesthesia, and they'll even die. Then you go to cross the ocean, the British Royal Society, very close to that year, with Harvard Medical School. They put some statistics about deaths and injuries caused during or after anesthesia or by. So in 84, everybody knows the ASA score, the Anesthesia Society. They tried to come, they gathered as specialists and created the Foundation of Anesthesiology and Patient Safety. And then they started to grade also the types of ASA 1, 2, 3, 4 that everybody's aware. And also in the same time in Australia, there was a big movement from their group. Well, what happened is that patient safety currently is very well recognized in many countries, especially ours, that it is an important topic. The World Health Organization identifies that as something that is important, required to be paying attention by hospital administrators, by the different associations, and this trigger associations to create the American College of Surgery has ASQIPs, ANQIPs, and even the American Urological Association has. And one of the speakers here, Dr. Chris Gonzalez, can tell you a lot about quality improvement and all the issues related to that. But patient safety became a new healthcare discipline. Actually, there are patient safety officers, quality officers, and some hospitals, some people say, oh yeah, that's the internal affairs guy. And it's something that brings a little bit of more attention, red flag, and it is very important to have one person that knows what surgical procedures are for our specialty, and also understand the medical side, like hospitals and so on, to understand how the patient safety issues are different. Um, so what happened during this period, the decades of 80s and 90s, is that this boom of information, people researching how many people were getting hurt with medical errors or getting killed, this created a huge body of literature. And in end of 1990s, the Institute of Medicine created this report, The Error is Human. That demonstrated that 44,000 out of 98,000 preventable deaths annually were due to medical errors in the hospitals. 7,000 preventable deaths related to medication errors alone. And this really triggered to the end of the spectrum from observation to political action, which when Bill Clinton was president, they had a special commission and reports and recommendations given. So from that, what triggered globally, other countries like Britain with NHS, National Health Services, and the Australian government, Australasian, including New Zealand, they started to study all that. And if you see what the Department of Health expert group in June 2000 recently estimated that over 850,000 incidents harm in the National Health Services Hospital in the UK each year, you can on average 40 patients a day contribute for patients' death. So that's a huge number. If you try to save one patient and you have another 39 that are contributing to death of one patient, I mean, this number is huge. It's incredible. So these are reports that demonstrated what the problem is and even how the number of patients are getting hurt and the magnitude of the problem. What do you do with that information? Well, people have been studying several things since the beginning. There are different ways that you can approach the problem, and safety has been an issue in all other industries, like aviation, car industry, any kind of industry where patients have to construction, people can get harmed, employees can get harmed. So psychology, psychiatrists, workman's comp, all these different specialties started to study. Human factors is a very important thing, as you know. For example, we know that one very important Korean flight that killed more than 290 patients, because in Korea, you have 3 years of military school. The pilot was more senior, and all men go to military service, and the co-pilot was more junior. He knew that the pilot was doing some big mistakes, but he didn't say anything because of the culture of hierarchy. And more than 290 lives were lost. So if you study all that, and they started to study all those incidents and accidents, and they found out the human factor is very important. So what the analysis of these issues, it started to intersect with how a person think, what they learn, how they perceive things, and how they can interact with the technology and the services that he has or she has to provide. So what impacts human performance is we usually tend to underestimate our abilities, right? Or overestimate. So we are all probably guilty of this. No, don't worry. I'll do this case. Yeah, you can book the other one on the other case, on the other room, and I'll follow up and I'll run to the clinic, do a quick biopsy, come back, and oh yeah, I'll pick up my kid between the biopsy, the cysto, and partial nephrectomy. But I will have time. But there's a traffic. Where do you live? Oh, I live in New York. Oh, that's okay. Don't worry. I'll take a Uber. No, that's we gotta know our limitations, but we cannot overestimate things. Bad things can happen during that time. And right now, the next slide, I'd like you just to take a look and try to read the caller, not the word. I know it's very early in the morning. So it is a little bit tricky because first you have to speak English. Second, I think you can't have color blindness, I think. But you gotta, it's very difficult because you're trained with one thing. When you see the words pink, you think you're seeing color pink, but this is not pink, it's purple, I think. I can't even see it at all. But this is a clear example that I can show real time that what you see is sometimes it's not what you see, there's so many factors that influence that perception. So what impacts human performance? External factors. Now we are in the operating room, and there are general surgeons working on that, orthopedic surgeons, even urologists, that in the operating room, for example, if you have external factors like noise, distraction, interruptions, the task design is so complicated, environmental conditions, it's too hot, too cold, can decrease your performance. Internal factors, if you fatigue, running around, not sleeping well, stressful because of your RVUs or your manager that is a pain in the neck, you're having depression because you're going through a very difficult time, those have to be taken care of. So we did a systematic review, and this June we put in the cover on urology practice the James Reason's cheese model. The cheese model, if you stack up slices of cheese, Swiss cheese, there are holes, right? If the hole is it's all the way through, if you start a problem here and there's several mistakes, there's nothing that can block that. It will go through, but the hole has any kind of blockade there, that's your first way that you can avoid a problem that was small to be large. An example in the operating room, there is the preparation from the OR, the operating room, and after. Simple case. Antibiotic allergy. So the antibiotic allergy, if you see on the pre-op and you tag, and in the operating room is given whatever protocol 30 minutes before or during, but if it's not seen and you give that penicillin that patient is allergic to and have a bad reaction, if you didn't have this red flag here, you will not be able to attend to this problem and avoid any complications. This is the Swiss cheese model. It means if this was not done, the hole would be all the way through, and this would not be alert sufficient to that. So that created the word system thinking. It's the new ways of thinking the work you do. It depends on habits. It depends on the events that you experienced, patterns of behavior, system structures, mental models. But the most important message is take that opportunity to learn. The most important, communication. Even your deep feelings and get a feedback and don't think that feedback is against you. It's probably taking you to a different level so you can communicate better. So this is the AUA University Core Curriculum under ethics that you can check. There's some things that we try to put specific for urology, endourology, radiation safety, and so on, that can increase the patient safety, but also your safety. And the key role components that determine safety is how you use your tools, technology. Uh, Ergonomics is very important for you also, because if you're having paresthesia because of your C-spine, your ergonomics is important. The environment, if you cannot operate with rock music, don't do that. But you gotta align with your organization. Talk to your patient safety. Get to know that guy that wears the patient safety hat in your organization. Makes financial decisions. Tell them that it's not about only money, particularly now that we're going to value-based care, Operational decisions, how many people we're gonna cut on this part, that part, and be involved in policies and procedures. And we can talk about other things about SPAR, DMAC, Toyota Lean, and Six Sigma that are coming for you to learn about healthcare. But this is the AUA is preparing a bunch of stuff for urologists to understand and trying to get a different way of thinking, because now you really have to be aware of patient safety to protect yourself. And it is very important to really align with the organization you work with, because now I think everybody is an employee of somebody. The last slide is, again, communication is key for everything. Please improve your communication skills and continue to work with your team.